slides from scratch, but it was interesting learning opportunity for me and get my thoughts together. So here we go. Next slide, Mitch. So being a little bit of a history buff, I'll just introduce you to some of the historical aspects of bronchitis. Gustav Killian, who's a German physician, has been credited as one of the first persons to have discovered or performed a bronchoscopy. And this was in late 1800s, early 1900s. And he was able to successfully take out a pork piece from the bronchus of a patient. Next slide, please. Here in our own country, Chevalier Jackson has been credited as the father of bronchoscopy in the United States. And to his credit, as you know, the initial bronchoscopes were mostly rigid bronchoscopes. And in a rigid tube going down your bronchus, obviously it is pretty dark inside and it's very hard to see. And he was credited to have first eliminated rigid bronchoscopes. You can inspect the airways much better. He is also credited of removing over 2,000 artifacts from people's airways. And if any of you have interest in this, all of those artifacts are stored right now in the Mutter Museum in Philadelphia, where he practiced all his life. Evidently, he was born in Pittsburgh, pretty close to us. Having said that, next slide, please, Matt. What we are familiar with as the bronchoscope was actually devised by a Japanese physician, Shigeru Akita, and he's credited as the innovator of the flexible bronchoscope. Since his discovery or innovation of bronchoscope in 1960s, we have undergone significant advances in reiterations of these fiber optic bronchoscope, but general principle stays pretty much the same. Next slide, please. And here are some of the latest bronchoscopes we have with significant improved working channels, illuminations, and different sizes. General bronchoscope is about 50 to 60 centimeter in length and has a working channel which ranges from 3 millimeter to 4 millimeter in size. Next slide, please. So typically in a bronchoscopic procedure, the physician stands by the head side and the bronchoscope, the flexible bronchoscope, is introduced either through the nose or through the mouth. Moderate sedation is used. This procedure can be done electively or emergently. We often use this procedure in ICU patients to figure out unresolving pneumonias. We generally have a video monitor so we can in live inspect the air. A very important aspect, since this talk is focused on lavage, the core concept of lavage is that you can get an alveolar sample. So if you focus on the right side of the image, you will see that the bronchoscope is introduced and extended as peripherally as possible until it wedges into the smallest of the bronchus. Once it is wedged, then the likelihood that it'll be contaminated by central airway secretions is very minimal. And that's the core principle of lavage, is that we are looking for a sample of the alveoli, which are absolutely the most distal part of the lungs. And in order to get a pure and good sample of the alveoli, as distally and then block that distal bronchus in order to get a good sample. Next slide, please. So this slide should be labeled actually unsatisfactory sample. Chamberlain and his colleagues had described as to when do we know that this is a good sample to even evaluate. So A bad sample would be if there were not much alveolar macrophages. So if you look at a sample slide and you don't even see 10 alveolar macrophages, then that should raise the suspicion that maybe appropriate wedging was not achieved, and there was significant amount of contamination in the lavage. Extensive epithelial cells noted in the sample, that also reflects that a lot of central airway contamination might have occurred. Numerous red blood cells in your sample also suggest a poor sample. It also suggests airway trauma, especially a bronchoscopy done novice or a trainer who can cause significant airway trauma while doing the procedure. Any presence of significant pus, mucopurulent exudate is also suggested that a good wedge could not be achieved. If you have a lot of degenerative changes, more than 20% of the slide considered as a poor sample. So these are some important aspects, because the idea is to get authentic information on the basis of which you can act and diagnose. So a key concept is to make sure that the sample is appropriate. Next slide, please. So now comes as to why do we use a lavage? What are the indications and how can we utilize it to the best capacity? So one of the most common indication, of course, as I alluded a little bit earlier, is a non-resolving pneumonia. Ideally, any pneumonia, which is a community-acquired pneumonia, should start responding in 24, 48 hours, at max 72 hours. But absence of any improvement in 72 hours is maybe the bug or the infectious process is not being covered by the infection, or there is a non-infectious etiology to the respiratory compromise or failure. We often use bronchoscopy and lavage in patients with diffuse lung infiltrate. A good example is an abnormal chest X-ray in a patient who's been having dry cough. When you have no sputum production, it's very hard to analyze what's going in the lung. And this is a very handy procedure at that time, where you can slide down, take a lavage, and diagnose this condition. I remember many years ago, we had a refugee from Tibet who had been having a dry cough for almost 8 months, and all the chest X-rays had been normal. Everything had been tried to resolve the dry cough, and we were unable to do that, and eventually landed up deciding to do a lavage. And a lavage is right upper lobe, which revealed AFB, or indicating that patient had tuberculosis. So TB can sometimes hide in the upper lobes and not be very easily visible on chest X-ray. And having symptoms which are persistent, lavage can help you narrow down the differential diagnosis. The other indications are suspected alveolar hemorrhage. As per usual, that if you have an alveolar hemorrhage, that you will have a hemoptysis, is not always true. There's a fair significant number of patients who may have alveolar hemorrhage but not have hemoptysis accompanying it. So you have an abnormal chest X-ray and you don't know why this patient is having shortness of breath. Lavage can be pretty diagnostic in finding out about the hemorrhage in the lung. Again, quantitative cultures in ventilator-associated pneumonia, this is extremely helpful. We use it very often in patients in ICU. ICU patients tend to be sicker. They sometimes are on the ventilator for a prolonged period of time. And may develop and infiltrate, and we need to figure out if this is pulmonary edema versus an infectious process due to the ventilation. And a bronchoscopy with lavage is a very important tool with us to help us in this process. Bronchoscopy with lavage is specifically very important and useful in patients with immunocompromised hosts, whether it's HIV, solid organ transplant, bone marrow transplant. Patients have abnormal chest X-ray, may have shortness of breath, but may not have much productive sputum. On top of that, these patients also often have low platelet counts. They may have associated renal failure, which makes biopsies very difficult. And these people may have significant bleeding complications. And lavage is helpful to diagnose infectious or non-infectious etiology in these patients. Of course, post-transplant monitoring of lung allograft to look for acute lung rejection. Graft host rejection is an important reason for doing lavage in bronchoscopies. And many a time these days we're using for research purposes, which I'll allude to later on in this slide, please, Mitcha. Thank you. The idea about lavage is to get a sample of the alveolar. So just to kind of give you a trivia, 100 ml of fluid injected into the distal part would sample about 1 million alveoli in our lungs, which constitutes 3%. So although it does not appear a large part, but a 1 million alveoli seems to be a reasonable sample to understand what may be going on in the distal part of our lungs. Where do we lavage? Well, common sense dictates that any areas where there's a radiological abnormality is where we need to go. Now, if your X-ray may not have too much abnormalities, or if it is diffuse all around in the lungs, in that case, we prefer a right middle lobe or the lingula, just because by the nature of the middle lobe, there's a much better output and collection of than in other segments of the lung. Recovery of the fluid is significantly reduced in smokers. So it's important to understand that if we are able to recover 50 to 80% of the fluid in a normal healthy person, this reduces to almost only 20 to 30% in a healthy smoker, which may mean that you may have to inject more saline or fluid into smokers because your output is going to be definitely less, and it may even be further reduced in patients with COPD. It's an important aspect we need to keep in mind. Fluid recovery is also decreased with age. Older you get, the less easy it is to get the fluid recovery from the lungs. As I alluded, performed under moderate sedation. We don't need to intubate or ventilate these patients. Can be done as an elective procedure. Although if the patient is hypoxemic, we sometimes do land up preemptively intubating for the procedure. Next slide, Richard. So it's very important to just have a patient of lavage, and it can be very helpful and almost diagnostic in certain conditions. Two conditions which come to my mind are diffuse alveolar hemorrhage. So sequentially, as you keep washing the lungs, the fluid gets bloodier and bloodier with each aliquot. And that's a sign that your lungs are bleeding. In general, if you had a little bit of blood in your, which was a spillover from, another area, then the hemorrhage or the redness of the fluid continues to go reduce with each aliquots. However, if you have hemorrhage in the alveolar level, it is opposite. The fluid becomes more and more redder, and I'll introduce some slides to give you a little more idea about how these things are seen on an observation of lavage. The second important condition, although it's very rare, is pulmonary alveolar proteinosis, and it has a very unique, opaque, and milky colored fluid coming out of the lungs, and is very suggestive and almost diagnostic of pulmonary alveolar proteinosis. So just by looking at the lavage, you can gain a lot of insight as to. Next slide, Mitchell. So this is what I was alluding to as diffuse alveolar hemorrhage. So as we do different aliquots, you see the tubes labeled 1, 2, and 3. The tube 1 obviously is much lighter, almost orangish in shade, but subsequent aliquots, which are represented by tube 2 and 3, are becoming more and more redder, which is diagnostic of alveolar hemorrhage. Next slide, please. Again, example of pulmonary alveolar proteinosis. Generally, the fluid which we collect from the lung has a very transparent, thin kind of quality. But if you start seeing this milky, reddish, opaque in the lungs, that's highly suggestive of pulmonary alveolar proteinosis. Of course, certain stains are required to confirm the diagnosis, but just by looking at grossly, you can very confidently and comfortably say that this is consistent with pulmonary alveolar proteinosis. Next slide, please. So BAL analysis, how do we analyze? You're more accustomed to analyzing blood. This is a little bit of a caveat since there are marked variations in normal ranges. So remember, as we talked and alluded, that age, smoking status, amount of fluid retrieved, all can influence the analysis. So because of these marked variations in the normal range, sometimes can be hard to analyze lavage. However, there's one key component which I think is a good take-home message, is the predominant cell lines in a BAL is macrophages. So if I did lavage on everybody, 100 people, 85% of that sample will constitute of macrophages, which is not surprising because one of the main jobs of the lungs are to protect us from bacteria, which we are inhaling, and all the other particles, and macrophages are known to protect us from that and eat away anything which may hurt the lungs and the body. So if you remember that macrophages is your main cell line, and everything is dependent, we analyze and how we create a differential diagnosis on the presence, absence of these macrophages. Next slide, please, Mitchell. So this is again a set of patients' cell lines. As you can go down, you can see macrophages constitute, as I alluded, 85% of the cell lines. And lymphocytes are the next in line, constituting anywhere from 10 to 15% of the. And the next is neutrophil, which are less than 3%. And the least number are eosinophils, which are barely 1 to 2% of the sample size of the lavage. So this kind of gives you a baseline of what to expect in a normal circumstances. And if you have this normal template, what would abnormal look like? Next slide, please. So let's start with the neutrophils. As I alluded from the chart before, in general, you shouldn't expect more than 3% neutrophils, the normal range being 1 to 3%. So if you find a sample in which you have significant increased neutrophils, then you start suggesting and thinking about certain disorders like interstitial pulmonary fibrosis, ARDS, Infections can lead to increased neutrophils, connective tissue disorders, Wegener's granulomatosis, and sometimes pneumoconiosis and occupational lung disease can also show increase in neutrophils. Now you'll be noting that the differential diagnosis is quite wide. So as is the nature of lavage, it is helpful in pointing us in the right direction, but in majority of the cases doesn't clinch the diagnosis. So if you have a clinical history which is suggestive of infection or pneumonia, then an elevated neutrophil confirms that thought process. And same way, if you're thinking of ARDS or IPF, having an increased neutrophil count supports that clinical assertion. Next slide, please. Now it comes to eosinophils, as I also alluded in our template slide, that there are very few eosinophils present in the lavage, less than 1 to 2%. So any presence more than that of eosinophils suggesting abnormal going on at the pulmonary level. We generally dichotomize eosinophil as low eosinophilic count or high eosinophilic count. In the low eosinophilic count, which is moderate, mild to moderate, which is 5 to 20%, is still quite elevated, is mostly seen in drug-induced lung injuries, for example, who may have an allergic reaction to penicillin, nitrofurantoin, or minocycline. Infections, specifically parasitic infections, fungal infections, mycobacterial infections, can cause eosinophilia in the lungs. As you can see, that bacterial infections don't cause eosinophilia. So it's a great way if you're suspecting somebody who's had international in with lung infections and a round of antibiotics and treated, then you start thinking about, hey, could he have picked up a parasite or a fungus on the way or a mycobacterium, and this would be helpful. Patients who have known asthmatics can have eosinophilia, and certain malignancy, not all, but in certain malignancies, you can see eosinophilia. If you have marked eosinophilia, which is defined as more than 20% of your sample constituting eosinophils, then you start thinking seriously about acute or chronic eosinophilic pneumonia. An important thing to remember about acute and chronic eosinophilic pneumonia is that these do not respond to antibiotics. It is basically steroids to suppress this immunological response. So it's very important to quickly come to this diagnosis so we are not unnecessarily prolonging the disease by giving rounds and rounds of antibiotics. So marked eosinophilia in lavage in a patient you're suspecting of unresolving pneumonia is highly suggestive of acute chronic eosinophilic pneumonia. Patients with underlying asthma may have underlying cystic fibrosis and have marked eosinophilia may be suggestive of ABPA or allergic bronchopulmonary aspergillosis. Another vasculitis disease, which is much rarer, but also can see marked eosinophilia, is Churg-Strauss syndrome. Next slide, please. Now coming to the third line of cells, which is the lymph. As I alluded, the normal cell count of lymphocytes in BAL ranges from 10 to 15%. And anytime there's elevation of lymphocytes, which is more than 15%, these are the thought processes that come through your mind. It could be sarcoidosis, could be hypersensitive pneumonitis, connective tissue related interstitial lung disease, drug-induced pneumonitis can cause lymphocytosis. Occupational lung disease like chronic berylliosis has been associated with high lymphocyte count in lavage. Radiation pneumonitis is associated with that. NSIP, or non-specific interstitial pneumonitis, and cryptogenic organizing pneumonia, also known as COP, are also associated with lymphocyte elevation in lavage, and so is the inflammatory bowel disease. Next slide, please. So having said that, again, sometimes the level of lymphocytes further hone down your differential diagnosis. For example, if you have marked lymphocytosis characterized by more than 30% of your sample constituting lymphocytes, that is highly suggestive of hypersensitivity pneumonitis or non-specific interstitial pneumonitis. Low grade of lymphocytosis, which is less than 30% but higher than 15%, is very consistent with IPF in the correct settings. Next slide, please. Now, these are some of the non-infectious areas which it can be helpful, but as I alluded, it can be very helpful in infectious workup. For example, non-resolving pneumonia is one of the things which I alluded, is sometimes you may not be covering the appropriate bacteria. Maybe the bacteria is resistant to the antibiotics which you're given, in which case bacterial gram stain and culture sensitivities can help you the right diagnosis. Direct fluorescent antigen testing can be done on the sample of respiratory secretions and the lavage, and it's very quick, can come back within 2 to 4 hours, so it's going to be very helpful in diagnosing Legionella. Other thing which we can do is look for galactomannan immunoassay, which is a test for fungal antigens, specifically aspergillosis. So specifically in patients who may be immunocompromised and at a higher risk for fungal, this test can be very helpful. Again, in patients who are immunocompromised, may have had bone marrow transplant, other transplant, who are prone to getting viral infections, specifically CMV pneumonia, shell vial immunohistochemical assays can be done to stain for macrophages for antibodies of these viruses. Fluorescent or silver staining for patients with PCP pneumonia, especially in HIV, and KOH staining for fungal diseases are helpful tests which can be easily performed on the lavage samples obtained from the lungs of a patient. Next slide, please. They can also be helpful in cytological analysis. For example, certain tumors, specifically the ones which are diffuse, like bronchoalveolar cancer, lymphomas, can sometimes be picked up on BAP staining. Periodic acid shift staining is helpful in identifying these lipoproteinaceous material, which is gives the quality of milkiness to the lavage and is seen in pulmonary alveolar proteinosis, which we discussed earlier in the lecture. Prussian blue staining is also very helpful for hemosiderin-laden macrophages. So if somebody is bleeding, has an alveolar bleed, then they will be testing for Prussian blue staining, and more than 20% of these stains would suggest a diffuse alveolar hemorrhage. Similarly, certain rare conditions like Langerhans cell histocytosis can also be diagnosed with lavage by staining certain CD1A antigens, and 5% or more of these is required for the diagnosis of LCH. Similarly, as I was alluding, that certain occupational disorders like the beryllium, chronic beryllium exposure can by a certain test called beryllium lymphocyte proliferation test, and the samples of the lavage can be subjected to this BAL test for chronic beryllium disease. Next slide, please. A very useful test is flow cytometry. So lymphocytes also have subpopulations. So there are different types of lymphocytes. Like the big ones which we generally deal with are the CD4s and the CD8s. So not only is it helpful to know how much is the lymphocytosis, But what does the subpopulation constitute? For example, patients with active sarcoidosis would have elevated CD4 to CD8 count. So anything more than 4:1 ratio is highly suggestive of sarcoidosis. Asbestosis, berylliosis, Crohn's disease, and connective tissue disorders all can have elevated CD4 to CD8 count. On the other hand, a low CD4 to CD8 count is highly suggestive of hypersensitivity pneumonitis, silicosis, drug-induced lung injury, cryptogenic organizing pneumonia, and next slide, please. We can also have significant information gained from lavage, especially in drug-induced injuries. Just like any other organ in the body, especially like the kidneys, lungs can get injured by some of the medications we are taking. Hemosiderin in macrophages is highly suggestive of diffuse alveolar hemorrhage. Mineral oil can damage lung parenchyma and cause hemosiderin deposition. Amphotericin B, which is a very powerful medicine, an antifungal agent, can also cause diffuse alveolar hemorrhage and can be picked up from this hemosiderins. It's, with CD4 elevation can be seen in toxicity with amiodarone, methotrexate, nitrofurantoin, cyclophosphamide, and sulfasalazine. So all of these medications can injure lung, and it's very helpful to have lavage and see if this is consistent before stopping the offending medication or the agent. Similarly, neutrophils go quite high in the lavage in patients with bleomycin or busulfan toxicity. Eosinophil levels, as I alluded earlier, can go high in penicillin and ampicillin allergic reactions or toxicity. We can stain the macrophages for oil or red stains, which is very helpful to determine if there's a mineral oil damage to the lungs. Many patients use mineral oils as nose drops. And recently, you're probably aware that before we went into the pandemic from COVID-19 last year, we were dealing with an epidemic called EVALI, or e-cigarettes or vaping. And one of the markers of vaping disease, which affects the lungs, is the oil or red stains and the presence of fat emulsions in the lung. Next slide, please. And this is a good slide to talk about certain research aspects as well as utility of lavage. When last year we had the vaping crisis, an epidemic, we decided to set up a task force here at WVU, lung injuries secondary to vaping. So anybody who was admitted to the hospital essentially for vaping injury underwent a bronchoscopy with lavage. And of course, one reason for that was to diagnose, to see if there is lipid-laden macrophages, which you can see on the left side of the slide, which is stained positive for oil red O stain. And the presence of these lipid-laden macrophages, any infection inside and a history of vaping was a conclusive diagnosis of EVALI, or electronic cigarette-related lung injury. And we looked at 17 consecutive patients admitted to our respiratory unit for compromise from e-cigarettes and vape. And 15 of these underwent BAL or lavage. And not only they were positive for lipid-laden macrophages, we were able to stain Prussian blue stains to suggest that there was bleeding or alveolar or hemosiderin-laden macrophages, suggesting that these patients had very severe lung injury based on being injury. So this is a good example of how we can utilize lavage in diagnosing even rare conditions and epidemics by having a clinical suspicion and then confirming by the presence of these highly suggestive findings in the lung lavage. Next slide, please. So complication, overall, it's a very safe it on a daily basis. However, it is not immune like any other invasive procedure. There are complications. Remember that we are not designed to have a tube down our breathing tube, so that can relate or cause significant coughing. We have seen in rare occasions severe bronchospasm, especially in patients who active airway disease or pre-existing asthma, and this can happen. Specifically when you are injecting saline, it can be a very pro-inflammatory action, and we can see patients suffering from transient fever for the next several hours to sometimes up to 24 hours. Because we are injecting normal saline and all of it can be taken out or evacuated, there is a transient worsening of the chest x-ray, which we often see, which is nothing but the residual normal saline, which has been left behind in the lung, which over the next 24 to 48 hours then gets absorbed by the body. Just because we are pumping fluid, minimal of about 100 cc's into the lung, we can sometimes see a transient drop in oxygen. And that's why whenever we are planning this procedure and we think that the oxygenation is borderline, patients with oxygen around 88 to 90, we have to consider whether it's safe to do this procedure, because you will see a further drop in oxygenation, or is this person better off to preempt intubated and mechanically ventilated before doing this procedure. And as with any other procedure, very occasionally we see patients going into respiratory compromise, which may necessitate intubation and mechanical ventilation. Next slide, please. So in conclusion, common procedure, very useful. Diagnostic instances include diffuse alveolar hemorrhage, as we alluded, pulmonary artery pertinosis, eosinophilic pneumonias, and infections can be very easily diagnosed. It can also be a very helpful adjunct for the diagnosis of several other pulmonary disorders. Complication rate is very low. It's a very safe procedure, much safer than doing a biopsy. And there's almost literally no absolute contraindications to this procedure. As you witnessed me discussing that even in immunocompromised patients, lung transplant patients, we do this routinely to either monitor the transplant or to diagnose any kind of a infectious process which may be taking place in those transplanted patients. So in a nutshell, it's a very useful procedure, and I would encourage you that anybody who's got abnormal chest x-rays, having vague findings of just dyspnea or a dry cough is a good patient. I'll end the talk with a recent case I saw. Is a patient who was sent here to WU for second opinion. Patient was in his mid-60s, had prior history of smoking, and had been coughing for almost 3 years now. And he described his cough mostly as dry, non-productive, even occurring when he's sleeping. Had seen slight worsening over the last 3 years, need by any fevers, any chills, and all workup has been negative. He had been tried on all kind of inhalers, and his dyspnea and his cough were unrelenting and continuing at the time when he came to see us here at WVO. During the interview, I was able to elicit a history that patient has a parakeet at home, and he loves this parakeet and takes good care of him. And that started me thinking that is this some kind of an allergic response which he may be experiencing. And considering that parakeets and birds exposure can cause hypersensitivity pneumonitis, I thought we should go ahead and lavage him. So we took him for a bronchoalveolar lavage procedure. Procedure was done, and lo and behold, in 2 to 3 days when the results of the lavage came in, it was predominantly lymphocytic in nature. And then further subset analysis of the lymphocytes by flow cytometry revealed that the CD4 to CD8 count was pretty low, less than 1, which was again very consistent with hypersensitive pneumonitis, at which point we had a very robust talk with the patient to get rid of the parakeet, which he did. We initiated him on steroids, and within 4 to 6 weeks, his cough had completely resolved. And he completed his course of steroids of 6 to 8 weeks. He, fortunately for us, got rid of the parakeet. He understood that that was what was hurting his lungs, and is doing much better. So these are some examples of how we have utilized bronchoalveolar lavage in helping our patients. So with that, I want to thank you for listening to the talk on a Monday morning, and I will welcome any questions at this point.
Thank you so much, Dr. Sharma. That was awesome, and I really appreciate the history that you included as well in the beginning. I've been looking over at the chat. I noticed everyone had some difficulty logging in this morning. I really apologize. We were kind of blindsided as well with the whole Zoom update requiring passwords now as that extra measure of protectiveness, I guess you could say. If anyone did not get the updated link, I'll make sure you guys get those. Just shoot me an email. I don't want to bombard you all with a bunch of emails. So just shoot me an email. I'll make sure you guys get the most up-to-date one with the password embedded into the link. So I apologize about that very much. Thank you all for being very patient with that. I did want to ask if anyone had any questions, comments, or thoughts for Dr. Sharma and his didactic.
Hi, this is Sam Giordano. I do have, thank you for that presentation, Dr. Sharma. It was excellent. I just wanted to ask you if you had any words of wisdom or precautions, given that we're in the midst of the COVID pandemic, with regard to the use of bronchial lavage.
That's an excellent question, Sam. And, we had recently published our guidelines in the ATS in this COVID era. And that included, and as you are aware, it's a highly aerosolizing procedure. So absolute precautions have to be taken. Personally at WVU, we have most of these patients tested within 48 hours for COVID-19 from the rapid testing method. And despite that, we obviously use N95 and do the procedure in a negative pressure room and take the necessary precautions of PPE. So very rightly said that as an aerosolizing procedure, with significant suctioning involved, you can aerosolize the virus and cause significant transmission to healthcare workers. So we minimize the number of people in the bronch suite when we're doing this procedure. All people in the bronch suite who are absolutely necessary are requiring adequate amount of PPE, which include either a PAPR device or N95 with eye goggles and gloves and all other precautions. So you very rightly said that this precaution, unfortunately, in this day and age, is very necessary.